All right, welcome everybody. I hope you all had a wonderful Thanksgiving. We're just going to give it a few minutes for everyone to join, and then we'll be kicking off shortly. Okay, I'll just give it another minute. All right, I guess I'll get started. So welcome everyone. We're excited to get started. Before I dive in, I want to go through a few quick housekeeping items. The webinar is going to be recorded. You'll receive a recording for the webinar following the conclusion. We'll reserve around 15 minutes at the end for questions and answers. Please submit them throughout. We'll be monitoring those and trying to get to all those questions at the end of the presentation. So with that, I'll introduce myself. I'm Kyle Mitchell. I'm the Senior Director of Operations over Integrated Care at Iris Telehealth. I'm going to be moderating today's discussion. And today we're going to be talking about how healthcare organizations are thinking about optimizing provider scheduling, driving operational improvements. We'll be digging into some of the challenges that organizations face, what your peers, our panelists have tried, what's worked, what hasn't, what they're planning going forward. We'll assess the benefits of leveraging virtual care and strategic partnerships, and examine some insights and best practices that have driven operational improvements. So before we begin, I want to introduce our panelists. I'm going to turn it over to them so they can introduce themselves. So we've got Julie Rayne, Behavioral Health Manager at Worcester County Health Department, and Cynthia McAfee, Director of Operations at Golden Valley Health Center. So let me turn it over to you to introduce yourselves.
I'm Julie Rayne. I'm a behavioral health manager within my local health department in Worcester County. We have an extensive mental health. We have a total of 13 outpatient therapists in our mental health clinic with 5 prescribers. And then we also have a school-based wellness program with 8 additional therapists that go into the schools and provide mental health services. We also have an addictions program that we run in an outpatient setting that does level 1 and intensive outpatient services. In that we are in a rural area, in that we are spread out. We have 4 different locations within our county. Transportation is a barrier within our county, so we have 4 different locations kind of spread out to assist our clients.
Great, thank you. And Cynthia?
Hi, I'm Cynthia McAfee, the Director of Operations at Golden Valley Health Centers. I'm responsible for one of 3 regions at Golden Valley. Just a little bit of history about Golden Valley Health Centers. We're an FQHC serving the Central Valley of California since 1972. So we started back in 1972 as a small hospital-based migrant health services program with a staff of 6 and 1 part-time physician. And we have grown to a system of approximately 50 total clinics, 290 providers, and more than 1,100 staff. So you can have an idea of the geography related to trying to meet the needs of all of our patients. And our clinics provide medical services, behavioral health services, psychiatry services, dental specialty, and rehab. But the mission has remained the same since 1972. Provide access to high quality healthcare for all, serving with dignity, respect, and compassion. Next slide. Just a little geography, just so you see our location in the Central Valley, north of Fresno, east of San Francisco, southwest of Sacramento, and the 3 counties that we cover, 4,902 square miles of the Central Valley with approximately 106 million in population for those areas. Next slide. This outlines the actual number of clinics within the counties that we serve. So Merced County is in the South region. We have about 10 medical clinic sites that also have BH services within them because we employ our BH providers, counselors within our clinics, and then 4 dental service clinics. Some of them are jointly located, some of them are standalone. Obviously, our largest county is Stanislaus County in both the North region and the Mid region with 38 clinical sites and 8 dental sites, and San Joaquin County, 2 medical clinics and 1 dental service site. So just so you have a feel for the geography, I think the geography is really important when you're a system, for sure. Thank you.
Okay, great, thank you. So we've recently rolled out our Iris Insights platform, and we've started digging into the data, working to optimize workflow and scheduling. And it's actually been a little bit enlightening, and I'm excited about this conversation because I'd love to hear from you both, you know, what you guys are thinking about from a workflow and scheduling. And then what would you say some of your highest optimization priorities are? So I guess, Julie, we can start with you if you want.
Our big mission in the past year and a half, we have received multiple grant opportunities. We've been lucky in increasing our evidence-based practice models within our therapists and ensuring we had specialties and concentrations. We found that the show rates when we had these specializations and our therapists had those evidence-based practice models, the show rates increased tremendously because the clients were more engaged in the services and they felt more vested in those services. So really focusing on our community and the needs assessment and what was the lacking of our evidence-based models, and then sending our therapists to get certified in those models has been a really big, and we've noticed over a 12% show rate increase with those evidence-based models and that. So just the investment, that's one clinical strategy that was definitely a high priority of ours. The other thing is optimizing caseloads within our therapists to making sure that the clients were seeing the frequency that they needed, that it wasn't that they stayed engaged and the momentum of treatment was continuing, that they could get into the frequency that they needed for their level of care. So it's optimizing those caseload sizes to make sure that the caseload size wasn't getting too big, that the clients couldn't get the frequency of level of care that they needed, as well as making sure the schedules are full. It's a scheduling and it's a balancing act between those two. So that has been a very focused on us, and we analyze that on a monthly basis. We look at schedules on a daily basis, weekly basis. Are the clients getting in? The therapist feedback, I need this client in sooner, they're having a crisis, my schedule is not. So it's a constant communication and balancing act with that. And then continuously working with our EHR on the confirmations, the reminders, confirming Trying not to be super annoying with too many confirmations, but having the right amount of confirmations, because if you get too many, then the clients complain about that too. So it's finding the balancing of that also. So those have been some of the key points.
Okay, great. Thank you. Cynthia?
Well, nice to hear we have so many similarities. Sorry, but you saw me smile and nod.
With being so vastly different in our size and the ruralness of where we are, where you are.
That's exactly right. We probably have a lot of similar, like the EHR confirmation calls isn't one of my top 3 for sure, but it definitely annoys patients when we make too many contacts, right? Too many. So probably first and foremost has to be working on reducing no-shows. I'm sure you probably experienced that. Kyle hears it intimately whenever we are meeting as groups with Golden Valley and Iris for sure. A lot of different pieces for trying to work toward reducing that no-show rate. We have hopefully we'll get into some of those strategies and other questions that you're going to ask, Kyle. A second really high priority is consistency in medical assistant support. We struggle with having consistent MAs that are trained across the providers that deliver psychiatry, no matter whether they're a pediatric psychiatrist or an adult psychiatrist. Just having consistent MA support and having the training for a couple of backup medical assistants as well. And third, not without least, is adapting to a patient accommodation procedure, which is truly, we're a walk-in clinic for many, many patients that live in the areas where we live, and provide care with our clinics. And so having the ability to find a way for a patient who walks in our clinic today that doesn't have an appointment today and doesn't have one in the future, but they found a way to get to our clinic today. How can we see them in some way today? Those are probably our 3 high priorities, Kyle.
Great, thank you. Along those lines, what strategies have you deployed or experimented with to improve the accuracy of your scheduling? And I'm thinking about things like that, seasonality, patterns, and overbooking. You mentioned some of the reminders. Anything there that you want to discuss?
Your voice is going in and out, Kyle, just so you know that. Can you hear us?
Yeah, I can hear you. I'm
Okay.
getting some background. I don't know where that's coming from.
I think we could try to answer the question. Do you want to go ahead, Julie?
Sure. A lot of things that we started doing is we were looking at schedules a week before, making sure the clients were full. We were looking at it 3 days before, looking at it the day before, and also keeping a client cancellation list for every single clinician that we have. So then the clerical staff already knew who they would call if there was openings that the clinicians wanted to get in sooner. So keeping that running list. Also, we also look at yearly patterns. With our school-based wellness therapists, they're in the schools, so it's during the school year. So we really utilize, and some of the kids, they go and stay with grandparents in another state during the summer, and we found those patterns. So other things we did is filling in our school-based therapists and taking on intakes and becoming, doing our intakes, and with that for new clients coming in. Also filling in if we had other staff out on medical, so we had backup to ensure clients are being seen if other staff are out on medical leave. In with that, because that was a pattern of trying to ensure that those clinicians still had things to do during the summer and the schedules were full. In that, we are currently not, I know one question was on that, are we overbooking or double booking or hybrid book, like in that? We are not currently. One thing that we're doing instead of that is we run no-show reports weekly of the clients, and we can see patterns of clients and which clients are no-showing. One thing that we have done to help with that also is when they come into treatment, they sign a treatment contract. If they miss 3 appointments in a row, they will be discharged from our services and have to be readmitted in that. After the second, we discuss is there a scheduling issue? Is there a transportation issue? Is there another thing to ensure that we can take away any barriers that they're having in getting into treatment? Sometimes they're just not, they're in pre-contemplation of treatment at this point, and they're just not ready to come in. Yeah, but we also have utilized, we have a grant funded program that these clients that are not engaging and not coming to our services, we go out into the community and we have a social worker and a case manager that'll go out to their homes and meet with them and explore what is their barrier and what is that, and try to see what's going on. So it's not affecting our schedules and our no-show rates, but we're also wrapping around that client of saying, do they need additional services? Do they need a higher level of care? Do they need our ACT team to go into their house? Like, what's really going on? And they do a full clinical assessment of their needs and then refers them to the appropriate level of care for them. So we've taken advantage of that. The other thing is that we're still working on is utilizing within our EHR is we actually have a meeting next week to talk about the mobile check-in. Like, we want to be able to do the mobile check-in. We want to be able to do the mobile. We're not quite there with scheduling yet because we have rules around our scheduling that our EHR is not ready to implement this rule, if that. But we are definitely looking at making it streamlined for our clients for the mobile check-in, smooth list of treatment. If they want to contact us, they can contact us through that and like text us, I would like an appointment, we'll call them and get them set up. So those are some of the strategies we're looking at.
We parallel that too, Julie. That's like very, very parallel. I don't know what EHR you use, but that electronic connection, we use Epic, so MyChart is the connection for a patient to enroll in MyChart, and then they can send messages that quickly get to a provider as well. So instead of sending it a very labor-intensive way of telephone calls, that return calls don't happen timely because they're with patients and they're covering another provider simultaneously, whatever that might be for a staffing crisis of the day. Yeah, so having that electronic piece definitely is what we're trying to emphasize for sure. And going into our next fiscal year, we're trying to do that check-in as an iPad in the waiting room as well, so they can get in quickly, because we've found the delays on the front end because, you know, the provider is, the patient's in line with many other patients in that clinic that are seeing a variety of different providers. And so the timing of their check-in really does matter for the psychiatry provider. And so what we end up doing is what we call reverse scheduling. We have the MA go out front and they've been cross-trained to do that check-in. They take them to the back, they do the check-in and get them in with the provider closer to the scheduled time so that we can make the day flow better. And then the details, whatever is missed, then they do it on the tail end of the session for that patient. One other visual thing that we've done on the Epic schedule is we're permitted to have a banner across the top. So we can say in that banner that this provider only sees patients 4 years and up or 8 years and up. So we can decrease the scheduling errors that come from many, many people touching and scheduling. We don't use the call center to schedule with us yet because we don't have a consistent workflow for them to use it. So we keep it more localized to all the MAs in all of the various clinics to do it. So.
Okay, great. Thank you. Can you hear me now? Is it better?
Yes.
All right, perfect. Thank you. I had to switch my microphone. So I guess the next question is, what operational improvements would you say your teams have made that have delivered the most success for your organizations? And Cynthia, we could start with you this time if you want to mix it up.
Well, you know, this is like my time to tout my the Golden Valley relationship with Iris Telehealth. So, you know, that is probably the largest operational improvement that we have gained. Very, very granular improvements at the clinical level because we have worked together with Iris to come up with a process improvement plan, and we have made it so that it is a constant, flexible work plan. We have tried things that seemed a bit onerous by the time we're in month 4 and month 4. And so then month 5, we change it and pull it back. We don't have as many meetings. We're not frustrating the providers as much. But honestly, we did a lot of what you've described, Julie, which is, you know, analyzing it down to weekly schedules of cancels, completed, and no-shows, and looking at what that, even for vacation days, you know, we pull those numbers off when we're looking at that. So then you get to see a month at a glance. We've fallen out of regular reports, but we're trying to get back on that bandwagon again with all the actual center managers in those 11 clinics that we have Iris providers in, so that we can look at that again. But it's been a great journey. Iris has been excellent in working through dashboards and improving a dashboard that we couldn't put together fast enough through our epics, you know, reporting. And so it has been wonderful to do that, and connecting, having great relationships with providers, having great relationships with center managers and the clinic supervisors of the medical assistants. You know, you need it all the way down to who actually rounds with the patients and what kind of barriers they have every day, trying to make that a much more fluid day for a workflow, and then turn those documents into a training document for really training 2 other MAs, because we know that someone's not going to be here every single day when the provider's here. So we have to be prepared for those pieces too. So that's what I would like to say our biggest biggest positive, most success for sure.
I think like our biggest success in knowing and even is really is when we started continuously with supervisors, managers, clerical supervisors, other programs, our TCM program, target case management program, bringing them into our meetings, bringing our medical assistants transportation supervisor into our meetings, making sure that we're communicating with them and saying, okay, we're going to be doing this in transportation, and making sure that we're lumping the people where they live with their transportation with medical assistants to try to help them out on their transport. So it's really bringing multiple teams together and communicating on how we can do it. And then also bringing the therapist on board, of them having those conversations with their clients regarding the importance of their engagement in treatment. And it's not, that's a clinical strategy as well as a show rate strategy in that. Letting the client know from the start, if this is not a match, you're not going to hurt my feelings. We can transfer you to another therapist. And what we found is sometimes it's just not a match. And then you transfer them and then they attend every appointment. And it's that constant communication between the client and the therapist, the other programs, the supervisors. It's just a teamwork approach. And I can't say enough about our Iris therapists and the way they micromanage their own schedules, and they own their own schedules, and they just balance it. And if they have a client, they have their list. If they have a client they want to see and they know they see, they just reach out to them. And if someone no-shows, they get that client in and see them. And it's ensuring that they're getting the services they need, but they're also accountable to their schedule and they own it. And I think having the therapist own it, the clients own it, and the supervisors own it, and everyone own it together as a team has made a huge, tremendous difference.
All right, great. Thank you very much. So you mentioned no-show rates, and I'd like to actually talk about that now. They're obviously a challenge for everyone, and I would like to discuss, I guess, how you handle them today, and where do you see areas to improve to reduce those last-minute cancellations and no-shows? And is there anything that you've come up with to fill those gaps, I guess, when they happen? Let's go, Julie, I guess. We'll start with you. I think you need to be unmuted.
You've struggled with since day one. On that, I think having those list of other clients in the wing, because I mean, things happen with clients and you're gonna have it. We always strive that we celebrate the months that if we're in 85% no, like 85% attendance, we are very happy in that. When we started this, we were looking at 50s and 60s, and now we're consistently about 75, and there's months we'll hit in the 80s. So seeing those improvements, and the clients are getting the services they need now. Do you know what I mean? Before it's like, okay, they're not getting the services they need, so there's something missing. But it's an forever tracking process, reporting, tracking. You can't let it slip, or it slips. If you're not looking at it, it's going to slip again. And it's a balance. When it's busy times of year, holidays and all that, it's easy. It's just something that has to be on the forefront all the time. And I think that's been the major strategy in that. It's always going to be a barrier, a struggle, I think. But looking at it and staying on top of it, I think, is the biggest thing.
And I guess a follow-up to that, have you ever considered, either of you, implementing cancellation fees for no-shows?
We are not allowed to. We are a state agency in that, and we have explored it, and we cannot.
And we are a federal qualified health center, and we're not really permitted to do it either. So, having cancellation fees is kind of basically closing our door to a patient that so desperately needs mental health services. So it is not something that we can do either. I think that what Julia described as looking at it weekly, looking at no-show percentages, and you look at show rates is what I hear you saying, Julie. We look at percentage of daily goal kept as well. So it's the combination of all three of those, special pieces. And, on any given day, did I have a substitute medical assistant that really didn't get the training they needed to do, to really have, in order to move through the process too, and be comfortable with it. So I think it is a challenge. One other thing that I want to look at as a goal for us this upcoming year is to utilize the Epic intelligence to predict the patients and their frequency of no-shows. So Julie, you mentioned that you run a monthly actual patient report of no-shows. I want to use the intelligence of the EHR to tell me already what their no-show rate is, because then it's my job to try to convince the providers to consider a double book. And that has to be a partnership with the providers for sure.
Great, thank you. And do you know what the most common reasons for no-show are? Cynthia, looks like you.
Transportation.
Okay.
Family situations and homelessness and transportation.
Okay.
Same.
I guess, along those lines, if you have a patient who's a repeat offender with no-shows, at what point do you stop scheduling them and they would have to start over, I guess, basically with their care.
In with us, they've done 3 no-shows in a row. In with us, in with that, we will then discharge them, refer us out to what I refer to as our START program therapist, who will then reach out and do the community-based in the home reach out.
I'm afraid we don't have that option for all of our locations. So maybe a couple of counties would be able to do that, but we'd be pretty far from any patient that is in the far reaches of the rurals to try to have that as an option. And larger counties can do it and they can support it, but our smaller counties can't possibly try to do that, which is pretty sad. It would be wonderful to be able to do that. What we try to do is we ask the provider to have the serious discussion with the patient.
Got it. Okay.
They normally do it.
And is there any difference in approach for different demographics? So how you're handling scheduling of adolescents and geriatric patients, or someone with a specific condition? Is there any difference there, Julie?
I'd say our adolescent is a little bit different because we do the school-based wellness, and we do a lot more in the homes with the kids after school and with that. So we do a lot more. They utilize our state vehicles, and they'll take the kid to their house after school and meet with the parent. You know what I mean? A lot more in-home services with the kids. I think we definitely don't utilize telehealth as much with our severely mentally ill schizophrenic clients. And with that, it's more in office visits, but we do utilize our case management and all that to utilize transportation and that for the compliance of that. We do also have a program for our high-risk clients in that we have a lead program that we work with the police on, and we have clinicians in there working closely with the police and wrap around with our crisis response team services. So we do those kind of wraparound services in with that. The one thing we do treat our substance abuse a little bit, all of our substance abuse appointments are face-to-face. We will do, we will on occasion, if we have a snowstorm, or if it's, you know what I mean, like that, we might convert it, but it's very rare. So that's kind of the different populations.
We utilize our counties for those severely mental health patients because we're the outpatient alternative at the lowest level of trying to bring them back up to functioning within their own house or with their own circle of friends and family. Probably the closest attempt is when we choose the actual geography, the clinic where we want to put that specific provider. Like we have a pediatric psychiatrist, and he is actually seeing patients in with a large pediatric practice in that same building. It's all telehealth, but we also have different versions of telehealth because when you're a new patient and when you're a child, I totally understand this of pediatric providers. They want to see them visually. So we call it face to video. Patient comes in with the parent or the guardian, and they're actually checked in and their vitals are taken by an MA in person. Then we sit them in the room where they're meeting with their telehealth provider. That's what we call face to video.
Okay, well, great, thank you. And then what are your plans for the future with implementing any strategies, anything? What's on the horizon? And Julie, we can start with you, I guess, on this one.
Some of our plans, I'm very jealous when she tells me which EHR they have. We do not have, that's the EHR of my dreams, that we can't afford, but I wish we had it. It is golden standard EHR you have, which I would love to have. But just continuing to build our EHR for our clients' convenience. We're trying to get all of our intake packet paperwork within our EHR. They can sign everything, sign their consents and sign their HIPAAs and sign everything. So it's a little bit smoother process. I mean, we are state, we are Joint Commission accredited, so we have a lot of mandated paperwork that people need to sign, and they're annoyed by it, but it's mandated. And with that, so trying to streamline that for the convenience of our clients, in that, and streamlining connectivity and streamlining everything to make it easier is definitely a strategy. We have looked at centralized scheduling. We have mixed feelings about centralized scheduling. Our locations who know our people, and we're a smaller community, and the clerks know who they see, and they know the frequency, and they know that, and then calling somebody they like to ask for a certain person. They have that personal relationship. So we're a little torn on the centralized scheduling. On that piece yet, but we're looking at it. And another strategy is really looking at the billing side of it, hindsight, to ensure that we're maximizing our visits. And with that, ensuring that if they did a treatment plan, they billed, and they can bill for the treatment plan, they did bill both sessions. So really looking at doing a strategy of a what I'm calling my scrubbing team. It's really my billing intense team who's in charge of looking the sessions, the length of the sessions they saw, looking and making sure that we build the appropriate codes and that we optimized our billing for that. Because sometimes you get missed out on that and how much is being, because therapists, they don't want to talk about billing. That's not what they're focused. You know what I mean? They understand it's part of it, but they don't like that being part of it. So it's kind of nice. They like all the help they can get with that.
I would definitely agree with all the pieces. I would also say that any EHR is not, you know, the top of the row if you don't have the ability to adapt some of the workflows and some of the pieces that are built in. So I just say that off the cuff because it's a challenge to get things built as well within Epic. But our goals are the same. We have to keep no-shows at the top of our list, and keeping providers productive is at the top of their list because they like to be busy, and it's hard for them to kind of team up without a partner that's their full-time partner, which is our challenge because we have MAs that go out on medical leave and we have to find substitutes for them. So our challenge is to keep training and retraining for those pieces and keep our supervisors engaged. And just like you say, clerical staff, those are our front office folks, and they're part of that care team in our world, front office and the back office with the MAs and the clinic supervisors. I think the other part of our goal is to tie that revenue cycle piece in with all of it. Ours are psychiatric visits too, but we always have opportunities, I am sure, when we do audits and those pieces that we probably haven't brought to the forefront as frequently as we keep no-shows on the forefront to keep going. So I think all of those things, and working out a way that we can negotiate with our providers so they'll be willing to see the first double book.
All right.
It's just one. We have to try one.
We have the same level of resistance on that here. It really scares them. It makes them nervous. It really frightens them. But our first attempt at that is we actually had a no-show kind of group. So we would track in together. So if they didn't, like if one showed, they would do an individual, but if they both showed, it would be a team and talk about barriers of treatment. It would be like a group session. So that was, they're willing to start there. But
wow, that's a pretty progressive approach.
yeah, it's definitely a resistance of providers.
All right, well, thank you. One last question before we look to the audience to see what they've submitted. But it's just, what advice would you give an organization looking to tackle some of the challenges that we've talked through today? And Cynthia, I'll start with you on this one.
Well, I spent a lot of time thinking about this one. You know, probably first and foremost, it is such a critical access need for patients that it is our obligation to do the research to increase that access. And that research really needs to include understanding your referral sources and trying to identify clinic locations that, based on that geography and access, will be your first success stories. Because honestly, if you can find your first success, it'll be easier to find your second one. So when we looked at geography, we looked at where our referrals were coming from. And right now we only accept internals because we have so many internal referrals. We can't accept external referrals right now. So we looked at geography, we looked at the ages of the patients in those referrals that were coming to us. And then we tried to make sure that we were looking at a 12-month run rate because of the calendar year and schools and what happens in the summers. We wanted to make sure we had a really good track record of those 12 months. Then we started with the first location and the second location, but the first one, we made sure we did, of course, you're going to do your financial modeling for sure. And you have to identify upfront what success is going to look like for your organization, because it's not always what it delivers on the bottom line, of course. But the timing of your recruitment is just as critical. We brought in one provider at a time, and it allowed us to learn our processes and our workflows and what wasn't going well. Then we could adapt them before the second provider joined. Those are probably, the biggest kind of common denominator is keeping the lines of communication open with your providers, with all of your care teams, and with your vendor, Iris Telehealth, because if you don't have those open lines of communication and the ability to take a criticism and turn it into an opportunity, then there's no way you can help our patients, is how I look at it.
Thank you. And Julie, do you have any advice?
One thing that we are continuing to do is we always go out to our partners. I mean, we partner with local social services, the parole and probation, our juvenile services, our schools, doctor's offices, and we ask for evaluations and recommendations from them on a twice a year. So if they're having barriers, we've changed our referral source. So it goes to an email now, and it's all electronic, so they can drop it in easier. Some of the changes that we had. So constant feedback from our partners to make it easier to refer to us. We have shortened our referral forms and that to make it easier with them. So, and also staying on top. We do monthly analyzing meetings with supervisors, clerical staff, and we sit in a room for an hour, at least an hour, depending on how things are going, and analyzing it consistently. And I think that's just something that just going to have to be done all the time. But I think the feedback, and we also do within our agency, we do an agency-wide client feedback. We do that twice a year. So they can give us feedback to us. Did they have barriers to get into treatment? Did they have transportation issues? Was their transportation issues addressed? Not. to kind of get feedback from our clients and having those open communications to look at future strategies and things that we can change.
Okay, great, thank you. And it looks like we do have a few questions that were submitted. So the first one says they're interested to hear about what you do for school-based clinics that are not staffed by medical provider, only BH. They're struggling with patient traffic at one of their school-based clinics that's not fully staffed. So any input there? And Julie, I'll let you go first.
And with our school-based clinics, we are not actually we're not a clinic within the school. We're a separate entity that is welcomed in the school to see them. We have, there's probably 3 different agencies that are within our school district in that. I think our biggest barrier to our school-based is space within the school sometimes. And being able to do that. We have a full-time adolescent prescriber that works with the schools and attends the school meetings and sees all of our kids. So staffing right now has not been an issue with our school-based clinic and us going in and being able to see all the kids.
I'm just going to touch base on Golden Valley does have school-based clinics that reside on the property of schools. They are primary care clinics that have part-time therapists or counselors that come in certain shifts throughout the week. So the doors are open when the school and beyond the school year for sure. We remain open even during the summers and the holiday hours for those primary care clinics.
All right, thank you. And the second question was they're curious if and how you work with other CMHCs or FQHCs in the area to understand more of the need. And they want to learn how you're establishing trust and getting in the door, getting the patients in the door.
In feedback of our clients, and we ask them how would they refer to our treatment, that's part of we ask at intake. And we also ask at our evaluations, and the biggest feedback we get is word of mouth in our community. And it's kind of that their friend sees so-and-so and recommended you to see so-and-so. So it's a lot of word of mouth within ours. We do work very closely with our FQHC within our community and with that, and we attend meetings together and we communicate all the time of what they're running into and what they're seeing, and that to make sure that we're not missing something. And if they come up with a strategy or we share our strategies with one another all the time.
I would agree with the word of mouth for sure, and with the primary care provider for us, because that's the link. So if I can have a provider, a telepsych provider, interact with a primary care provider within the EHR, or pick up the phone and cell phone call that provider, they're talking about the patient. They build that level of trust, and then both of them talk with the patient to try to have them come in and come to their first appointment with a telepsych provider.
Okay, great, thank you. And then how do you track the metrics today? And are you happy with your systems and technology, or are there areas you want to improve? Julie, I'll start with you here.
There's definitely areas, and there are definitely things I would like to be able to track in an easier manner within our EHR and not as manual work. We deal with staffing, difficulty hiring with everybody else from our front clerical staff all the way to therapists and prescribers in that. So when I can do a process that's easier and I can hit a button and get all the information I need, our EHR is great with working with us if I can tell them exactly what I want them to create, but I also need the funding to back that up. I don't always have the money to pay for the upgrades that I would like. Once that price tag comes back, sometimes I'm like, And I don't think that's going to happen. And with that, but yes, there's definitely areas within our EHR to track, to make it easier, to make it more systematic, and less staff intensive, because some of our tracking is very staff intensive work, that it would be a lot nicer if our EHR could spit out exactly what I would like them to track.
My guess is that everybody on the call would agree with that, Julie. You know, to want more automation. The hard part is to having the organization, whatever size it is, and have the support behind your IT workbench, that they truly understand the pieces that you're trying to extract. We can run reports a lot of different ways, but really learning about the details takes a lot of time and energy that maybe they're on 30 other priority projects that really have to run before yours for all these other rationales in your own organization. So it's hard to say that they don't have the abilities to do it. They just don't necessarily have the time available to do whatever we want. But I think that that's one piece where the directors of operation could step up and learn different pieces within Epic that we could report out for telepsych providers especially, or all other providers and different specialists as well.
Great, thank you. And then are there differences in how you communicate and track virtual providers? Julie?
The one key thing with the virtual providers that we have to stay on top of is ensuring insurance. They're not coming through that door to update their insurance, and right now we don't have the EHR connectivity. We're working on it for them to upload any changes or identify. They have to click if there's any changes in insurance. So we just have to make sure that we are making sure that they're signing all of the HIPAA documents that they need to sign on a regular basis. So there's a little bit more tracking with the telehealth providers to ensure we have all of the necessary signed documents, that they have signed all of their releases, that the releases are up to date, that they're HIPAA. When they come into the office, that's easy. But it's not as easy with the telehealth. So there's a little bit more monitoring with the telehealth of that. And we also, with the telehealth and ensuring, it's not much different of the tracking to ensure that they're seeing their therapist and the prescriber. But when they're coming into the building and the prescriber's in the building, that communication is happening on a continuous. So you have to build in those communication times. That sometimes being in an office, it just creates that communication time. Being telehealth, we create it for them. And making sure that communication is happening. So a little bit more tracking, also collections in that if they come into the building, we let them know what their bill is. In that if they owe anything, to making sure they're informed and that we're giving them good faith estimates and doing all those things that we need to do. It's a little bit more on the forefront, ensuring that we're catching them ahead of time and tracking them because we're not saying we're going to catch it when they come in.
Agree for sure. We assign a lot of those tasks to staff ahead of time, which is one of the calls that we make, that they don't like that extra call because we're trying to get all of those things performed ahead of time. And we really want them to sign up for MyChart because we can shoot those forms to them. They can just electronically agree to them and send them back to us, and then we can put them in their actual record electronically. The collections piece of it is always a challenge over the telephone because we also are, of course, we accept insurance, managed Medi-Cal, very active with our organization, but we also want to be able to offer them sliding fee discounts if for some reason they don't qualify for the managed Medi-Cal that particular month. So sliding fee has a whole nother set of documents that are required. So we're in the process of having all of our signature documents and sliding fee if we possibly can. That's the most complex one because you have to bring very specific items in prior to, you're shaking your head, Julie, you know exactly what I'm talking about, to verify your income. So.
Okay, it looks like we've got time for one more question, and it's, so have you discussed implementing AI into scheduling and workflow optimization? And if so, how could it be incorporated? And Cynthia, I'll start with you on this one.
That would be that double booking option, because AI would be smart enough to tell me that this particular patient has no-showed for this provider in the last X number of months, how many times. And then that, I could use that AI information and I would schedule accordingly and make sure I have 2 slots for that particular time slot for that day, which is always the challenge, because providers work off of very distinct schedules every day. And so, but it is possible. The other providers that are primary care providers at Golden Valley all have a built-in extra number of patients per day based on what their specialty is, because we have the assumed no-shows. So that's how we would like to use AI.
Okay, Julie?
We've discussed it. We have our Patagonia, that's our EHR. We meet with them and we ask them for feedback and give reports of other agencies that they work with. They're in multiple different states of whether they're using it, and kind of, we're letting kind of other people be guinea pigs right now for the AI, and then getting us feedback on it, on how it's working. We're holding back right now on it, but we are keeping our ears open on how is it working for other places and how has it benefited them, and then kind of exploring from there.
All right, great. Well, thank you very much. And thank you everyone for joining. Thank you panelists. You guys are awesome. We appreciate everything. As a quick reminder, we will be sending out the recording soon afterwards. So if you had any questions that we didn't answer, please don't hesitate to respond to that email and let us know, and we'll try to get back to you with an answer as soon as possible. So thanks again, and I hope everyone has a wonderful day.
Thank you.